Telemedicine, the practice of communicating with a healthcare provider online, isn't all that new anymore, but with the coming of the COVID-19 pandemic, its use and application have grown. It's one of the primary reasons often cited as to why rural states like Vermont would benefit greatly from an upgrade in the quality and coverage of high speed broadband service. Rural hospitals often don't always have all the specialists on hand to give in person service, so being able to connect a patient with a physician remotely, as the Southwestern Vermont Medical Center in Bennington often does with the Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire, makes that expertise available. We talked with Dr. Trey Dobson, SVMC's Chief Medical Officer, about telemedicine and how it works today.
In its basic definition, telemedicine is doing diagnosis and treatment from a remote location. So prior to fancy equipment, doctors would do telemedicine through a telephone. Years ago, tell me how you're feeling. What does it look like here? And then that's just, of course, evolved to the point where we're at today, where a pretty good physical exam and diagnosis and treatment plan can be done through telemedicine. There remain limitations. It is not the panacea that many people want it to be, at least not yet. And right now we're in a pandemic, so we've been utilizing it judiciously and effectively, and it's been a great thing to keep people safe and at home and not out exposing others and in putting themselves at risk.
What do you see as the main drivers of it, of the increase of its use? Is it cost, or is it a more efficient way of sharing information? What are some of the factors in play here?
Yeah, well, there are several. You're right to point out that there's several, and it really depends on the type of telemedicine being used and the situation. So I'll give an example. A real driver is workforce demands. Being able to deliver intensive care in a rural hospital requires that you have intensive care doctors and intensive care nurses and a lot of investment. Where when we use telemedicine, we can augment our current staff with those that are trained in critical care, and as opposed to bringing the doctors and nurses here locally. Now we do a mix of that, so I don't want to give the impression that we don't have doctors and nurses here. In fact, we have the same number that we did prior to the use of telemedicine, but it really augments and allows us to keep patients here who might otherwise need to go to a larger metropolitan area. So that would be the instance for telemedicine for an intensive care. There's also, we use telemedicine for neurology because we don't have a neurologist that's available 24/7 in the hospital, and that allows, again, us to keep patients here, but have them see a neurologist through telemedicine. Outpatient is a little different. Right now, back to where you were starting this conversation, we're in a pandemic. If people are sick, they shouldn't be out spreading the disease, but they need to be evaluated. So we can do so remotely through telemedicine. One in particular is that there used to be many barriers in place for a hospital or a doctor's office to recoup some of the expense involved in seeing a patient through telemedicine. And when the pandemic started and really got going, a lot of those barriers, legal barriers and legislative barriers and regulatory barriers were removed so that we could safely see patients, but also have some type of reimbursement from the payer so that the system would financially not go bankrupt, basically.
Do you see any difference in the kind of the quality of communication, for lack of a better term, when you're talking to a patient online or via a telemedical hookup versus when they're in the office talking to you face to face? Or have we got to the point now where it's so commonplace that really that barrier really doesn't exist anymore?
No, it definitely does still exist, and Andrew, I believe it will continue to exist in certain situations and for certain individuals, no matter how advanced the technology becomes. And that's the same for many things. We do a lot of online shopping these days, but people also appreciate and need to go shop in person. And it's the same with work. We can do a lot of work meetings, but you still need to have some of those in person, depending on what the discussion is and what the issues are and the people in play. So that's why I often say, and Ray hears me say, that telemedicine is not the panacea to replace in-person visitation, certainly, but it has a role, it has a convenience factor, and it has a safety factor that is quite appealing, and we are using it right now in this pandemic to a great effect.
So, with the COVID pandemic, how has it been? How is it brought into play in dealing with someone who either has symptoms of COVID or testing? Is there a way you're using that to try and analyze or mitigate the impact of the pandemic?
Absolutely. In fact, most people with COVID-19 do not need to come into a doctor's office and be evaluated, but they do need the guidance and the following from a doctor. So telemedicine has just been a wonderful way to connect with the individual, make sure they don't need to go to an emergency department setting, get them monitored and get them diagnosed. And the way we do that is we have the telemedicine visit with them. We recognize whether they need a COVID test. We then instruct them to come through the drive-through at the hospital. And so there's no exposure to our staff and to other patients. And then it's safer for the patient as well. They don't have to come into the system. That being said, there are patients that are ill and need some care in a express care setting or in our emergency department or even in our hospital. And so we can use the telemedicine to direct them to the right place, the most appropriate place. Again, for a vast majority, they have a sore throat and a fever or a cough and a fever. And we can do everything that's needed through telemedicine and then the drive-through testing.
For the GNAT-TV News Project, I'm Andrew McKeever.